There's actually some studies, I think, that it's confirmed that the amount of disease is not correlated with the amount of pain. In fact, it's almost the opposite, the inversely
Mm.
proportional, where the people with the worst pain sometimes have the least disease, and the opposite, those who are like, I'm actually not feeling that bad, don't feel a whole lot, but I'm having unexplained infertility, and someone does a laparoscopy, or they may on ultrasound have a huge endometriosis cyst that's discovered as part of a fertility workup,
Mm-hmm.
and it turns out that they have terrible disease.
Have you been diagnosed with endometriosis and wonder what's next? If you're considering treatment, is medication or maybe surgery right for you? Or maybe you have painful periods or you're struggling with fertility and you're curious whether you have endometriosis or not. This chronic inflammatory condition impacts 1 in 10 reproductive age women, but yet often goes misdiagnosed or undiagnosed and untreated for years. Today, we are going to review all about this common and important condition, endometriosis, with Dr. Karen Tang. Welcome to the Baby or Bust Fertility Podcast. I'm your host, Dr. Lora Shahine, a double board certified OBGYN and reproductive endocrinologist, helping people build family for over 20 years. And I am so excited to invite an incredible guest to our show today, Dr. Karen Tang. She is a gynecologist. She calls herself a geriatric TikToker. She has so much educational content across social media, and she recently published an incredible book called It's Not Hysteria, and it's explaining lots of misconceptions about reproductive health, including endometriosis. I am really excited to have Dr. Tang here on the show today. Welcome, Dr. Tang. Karen, welcome to the show. I'm so excited to connect with you today.
I love it. I'm so excited to be here. We've been waiting for this for a long time.
I know. You're a very busy woman. Your book is amazing. You've been on so many podcasts. You're doing so much to truly educate people, especially on endometriosis. I mean, this is such a common and often misdiagnosed topic. And I love what you're doing in your practice, but also all the education you're doing. I'm so excited to have you here to talk about it.
Oh, thank you so much. And this is, it's one of those things that, like, when I hadn't been doing social media yet, but I was just seeing patients in the office, and it was just so frustrating, story after story. Like, literally every patient with endometriosis had a very similar story of having seen multiple doctors, going to the ER, getting imaging studies, and kind of just being told, oh, you're normal. Like, we're not finding anything. This is just bad periods. And then, years later, we end up finding endometriosis when we finally do surgery. So, any opportunity I get to raise awareness, to, hopefully help people get that early diagnosis, rather than suffering for years and years, obviously I take that opportunity. So thanks for covering this topic. It's very necessary.
Absolutely. And I think that you and I have unique lenses on it, because we are often in different ways, like the third and fourth and fifth opinion. My patients are trying to get pregnant. And so maybe, symptoms have been controlled for a while and then they go off their birth control pills and it comes back, or they're just so used to being dismissed by other doctors that I'm the one that's like, no, like, tell me, like, what do you mean by painful periods, and trying to elicit, and you are a surgeon, you are seeing people in Philadelphia doing incredibly minimally invasive surgery. And so it's great because we look at it from different lenses, and I am excited to talk to you about it. So for the listeners, I mean, just the basics, what is endometriosis?
Yeah. So what is it? So I always explain it: tissue that looks very much like the tissue that grows in the cavity of your uterus, which is called endometrium. That's the tissue that comes out like period blood. Something that looks very much like that grows outside of the uterus. And it most commonly grows like behind the uterus, like there's a space between the uterus and the rectum. It can grow in the walls of the pelvis, in the ovary in the form of a cyst, or on the surfaces of the ovary, near your bladder. It can be on your bowel, on your appendix, like on your diaphragm. It can be all over the place. But kind of the most common symptoms we typically think of are like really painful periods, pain with sex, pain with bowel movements. I will even throw in there, and this is something that, as the years went on, having talked to a lot of people with endo, compared with what we were taught when we were in school and training, the bowel stuff is some of the worst symptoms. Like, I feel like when we were in training, it was like pain with periods, pain with sex, and that was sort of it, and infertility issues.
Totally.
But I will say a lot of the complaints that people have are really horrible bowel problems. So, diarrhea, diarrhea, constipation, horrible bloating, vomiting, pain with bowel movements, even blood in the stool. So, we were talking before we started recording. Dr. Karan Rajan, who's a general surgeon in the UK, has done a couple of episodes on endometriosis because a lot of people go to the GI doctor, the general surgeon, the primary care doctor first
Yeah.
because they're having such bad bowel problems. I guess a lot of times they've either gotten used to the painful periods or were told, well, that's just everybody has bad periods.
Yeah.
So they've kind of been like, well, I guess this is just bad periods. But the diarrhea is so crazy. They're like, this is not normal. So
Yeah.
they kind of go for testing for that. So I will
Yeah.
throw that in there too. If you're having, especially if symptoms get worse around ovulation or periods, worsened bowel or bladder symptoms, that's very suggestive of endometriosis as well. And it's one of the
Yeah.
more common causes of infertility. So in your world, what is it, like 50% of female infertility cases have some sort of endometriosis involved?
There's no way to know for
Yeah.
sure. I mean, that
Mhm.
number is sort of thrown around, but I think
Mhm.
there's so many people that have undiagnosed
Mhm.
endometriosis, and then we still are learning. We need more research. Is it an egg issue? Is it an implantation issue?
Mhm.
Just there's so much that we need to learn.
Yeah.
And part of what you're saying, I think, really adds to the delay in diagnosis. Average 7 years
Mhm.
of symptoms before someone actually gets a diagnosis, because partly, gosh, I finished medical school in 2002,
Mhm.
Karen.
Yeah, it was
So
2005. Yeah. Like
and maybe it was mentioned in my women's health lectures, which were very minimal.
Mhm.
And it was just like, hey, pain with periods,
Mhm.
pain with intercourse,
Yep.
infertility.
Yep,
And
that
we
was it.
didn't learn about all this other stuff. And so
No.
it's a lack of knowledge. And then it's
Mhm.
people having symptoms that are related to other things, that kind of leads to that. So you have to almost be suspicious of it,
Mhm.
as a doctor. And so that's why I think I diagnose so much of it, because I am seeing people with infertility,
Yeah.
or you are seeing people who are having pain, but there's so many
Mhm.
other ways that it can present.
Yeah, it's crazy when I see people and they're like they've been treated like a medical mystery for so long, and you're like, you have every symptom of endometriosis. It's like very unmysterious to me
Yeah.
because I've seen that pattern so much. And I say, like, let me guess, you have this, that, the other symptom, like you have blah 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 blah, and they're like, how did you know? Like, it's
Yeah.
because everyone with endo has these. But it is some of the things are so dismissed or
Hmm.
normalized. I say there's a lot of normalization of female pain, so that if you have a teenager who's missing school or throwing up, like they're just sort of labeled as like, oh, she's just like really dramatic, or
Yeah.
maybe she's trying to get out of going to school. And then later, oh, if you have pain with periods, pain with sex, throwing up, bloating, nausea, vomiting, diarrhea, constipation. It can also cause stuff like fatigue,
Yeah.
migraines, like these other systemic issues. People will sort of say, wow, not one thing can possibly be causing all of those things. You must just
Yeah.
be a hypochondriac where you're
Yeah.
over scrutinizing your body or something like that. It's like, what's it called? Like House, that TV show where it's like,
Yeah.
like there can't be one thing that's like explaining these million different weird things. But yeah, like endometriosis can explain all those things.
Yeah.
So actually, it's 8 years in the UK because there's such a waiting list to see a
Mm.
specialist there that it's even longer than in the US, believe it or not. So people will go for years and years, like trying different things. The story is very often they try one birth control, they try another birth control, like it works for a time and then it stops
Hmm.
working. And then they try the NuvaRing, they try the Depo shot, they try an IUDs, and they literally cycle through every possible birth control and
Yeah.
then kind of reach a brick wall where they're like, we have nothing else to offer you,
Yeah.
just deal with it. And no one brings up endometriosis. And so there's a lot of reasons for that. I think we can dive into that, but part of it is this sort of normalization of the pain, and like the assumption that if someone is experiencing a lot of different symptoms, that it must be mental or emotional rather
Yeah.
than physical. And that's a lot
Right.
of for so many things in women's health. So PCOS, menopause, perimenopause, same idea.
Absolutely. So, what is causing all of this? Like, that
Yeah.
was my first question. We're so excited to talk about, like, diagnosis and
Yeah.
advocating for your care. That is so important. But, like, to someone that thinks that they might have it or they get diagnosed, like, how do you explain to your patients, like, what is going on?
Yeah. Well, the funny thing is, what's causing it, I always tell people, we don't know what causes most things in women's health. And I hate to
Mm,
say that. When I was writing my book, It's Not Hysteria, I have chapters on each topic. So there's like an endometriosis, adenomyosis chapter, fibroid chapter, PCOS chapter. And Dr. Shahine was my expert for PCOS, infertility and miscarriage. Thank you so much for doing that.
no, you're so
And
welcome.
it was very depressing because normally in a book where you're like, okay, what is it? Like, what causes it? Like, how do you diagnose it? For the chapters, every single one, the what causes it, I'm like, we don't know. We don't know what
Yes.
causes endometriosis. We don't know what causes fibroids. We don't know what causes PCOS. Like, for so many other things in medicine, we at least have some sort of like, what's the origin? Like, where is there a gene? Is there an
Yep.
enzyme? Is there a process? For endometriosis, we're like, mystery. No one knows. Like, truly, no one knows. And it's
Yeah.
ridiculous because at least 10% of women, people assigned female birth, have it. Back to your point of that we just don't know how many people actually have it. Um, but after Roe v. Wade fell, a lot of people came in for sterilizations because they were scared about, what was going to
Hmm.
happen with reproductive rights. I did a ton of tubal sterilizations then, and I found endometriosis in at least, I kid you not, 2/3 of the people who I operated on. I should have
Oh,
written it up. I should have written a paper about this because
absolutely.
I started putting it on my consent form, like salpingectomy, sterilization, and excision of endometriosis, because I found it in basically everybody, and pathology confirmed. So just to go back to the, what is it, basic information, because it doesn't tend to show up on imaging studies unless it's relatively severe, like it's formed like a mass or a nodule or a cyst that's visible on ultrasound or MRI even. A
Hmm.
lot of times people will have very normal imaging studies. That's part
Hmm.
of the delay in diagnosis is people will get a million ultrasounds and even MRIs, CAT scans. They look perfectly normal
Hmm.
because initially it starts off almost like you're taking a pen and drawing dots on a piece of paper. It tends to start off really flat. So a lot of people will just not know that they have it
Yeah.
until you actually do a surgery. You look in with a camera called a laparoscope and you see it visually and you cut it out. It's called excision of endometriosis. And then the pathologist says, yes, under the microscope, we see that endometrial tissue. And that's how you get your diagnosis. And most of the treatment is cutting it out. So you remove as much as you can. But again, these people, most of them, like you said, had gotten started on birth control early on, stayed on the birth control for years and years, did a pretty good job controlling their symptoms. So they would never have gone for surgery and wouldn't have known that they had it. So it is extremely underdiagnosed.
Yeah.
I would say pretty much anyone, if you had really bad periods when you were a teenager and got started on birth control early, if that's your story, that there's a fair chance that you probably have endometriosis and it just wasn't so bad that, that you needed more treatment.
Yeah.
But a lot of people do, and the birth control isn't enough, or they need to stop it to get pregnant.
Yeah.
Obviously, you want to
Right.
get
And
pregnant, you can't be on
that's
birth
what I'm
control.
seeing a lot is people get started on birth control for symptoms. Even like heavy periods can be a
Yes.
symptom, or spotting, or,
Mhm.
like you said, pain with periods. And then they're ready to start their family. They stop their birth control and then symptoms start getting worse. And then I can kind of put together the pieces of the puzzle. I can say from my perspective, I've been practicing for over 20 years. So back when I was in fellowship at Stanford, back a really long time ago, we used to do a lot of diagnostic laparoscopies for
Mhm.
infertility. The field has drastically changed, and
Mhm.
very few patients actually just go to a laparoscopy to get a fertility diagnosis or figure
Diagnosis.
out what's going on. But I would say in that population, at least 2/3 of people would have endometriosis lesions.
Mhm.
And a lot of times people will have the lesions, but actually not have symptoms of
Yeah.
pain. And so that's another mystery. Like people can have
Mhm.
extremely painful, debilitating symptoms, and you look inside
It's like one
their
spot. Yeah.
abdomen and pelvis, and it's
Yeah.
like not, yeah, exactly. It's like not
Barely
very
in. Yeah.
impressive.
Mhm.
And then other people, their pelvis can be completely socked in with adhesions and endometriosis lesions everywhere, and they never have pain.
Yeah.
And I feel so when I'm telling people what is endometriosis, I try to explain it's a chronic inflammatory condition
Mhm.
impacting 1 in 10
Mhm.
reproductive age women, or people
Mhm.
with uterus and ovaries, and that it basically is a presence of this tissue that it really looks like what should be the lining of the uterus. Like you said this in the beginning,
Mhm.
but it's found elsewhere.
Mhm.
And to debunk another thing that I learned in medical school, I was taught that one of the causes of endometriosis is
The retrograde.
retrograde menstruation,
Mhm.
that it's this flow that should be coming out of the body, like through the
Mhm.
cervix and out of the body, but it actually backs up through the fallopian tubes and then implants. And then the
Mhm,
people with endometriosis, their body just doesn't clear up the lesions.
mhm,
And people without endometriosis, their body does a good job clearing it up. Like that's
mhm,
just like the basics.
mhm.
But that does not explain how some people have endometriosis in their
Crazy
lungs,
places. Yep.
in their brain,
Yeah. Mhm.
case reports of endometriosis. So it's just, it's
Yeah,
not that simple. Like everything
exactly.
that I learned 20 years ago
I know it
is
was wrong.
not.
So that's actually important because it's sort of the start of this myth that hysterectomies, taking the uterus out surgically, will prevent endometriosis in the future because
Mm,
they're like, well, if you have no uterus, then you won't have any more endometriosis. That's obviously not true. Like people can and do have endometriosis after hysterectomy. And I will even point out kind of interesting case studies wise. There's even been like cisgender men who have been diagnosed with endo, like biopsy confirmed endo. They tend to have like conditions where their estrogen is higher. The one of the few
yeah.
things we know is that estrogen stimulates it.
Hmm.
So it has been found in men. So obviously you don't need a uterus to have it. And just like you said, people can get it like in their chest cavity, in their brain, like in their belly button, like random places. That's a fun fact. Even if you've never had surgery, you can get it in your belly button, and you can have bleeding and a mass in your belly button that grows when you have your period. It's very weird. Not
So
that
that might be
uncommon.
from
Yeah.
the other theory is that sometimes just cells
Mhm.
will just kind of, from embryonic cells will just like turn into
Yep.
endometriosis, kind of like, all the cells in our body kind of came from a single
Yeah.
sperm and egg cell. That's the only way that I could have that make sense because
That's
the
the theory
umbilical
I
cord
believe.
is there.
Yeah, that just
Wow.
somehow when you were developing yourself, like in utero, that some of those cells that are going to eventually turn into uterus cells, like are
Yeah.
elsewhere, and they just kind of grow, and or that
Amazing.
people think that maybe it spreads through your bloodstream, your lymphatic system, like something that we just don't
Yeah.
know.
Yeah.
The theory about the retrograde menstruation came because a few things. One is that it's more common for it to be between the uterus and the rectum, like kind of behind the uterus.
Hmm.
So people think that maybe like gravity like pulls it there as opposed to in the front where like near the bladder is. Some people have endo near there, but it's much more common to be behind the uterus. And the
Yeah.
other is that there are certain congenital issues where you may have like a septum in your vagina or other uterine kind of anomalies that it's much more common to have endometriosis. So they think maybe, oh, you have a blockage somewhere and it is more likely to flow backwards, that those patients have more of a risk of endometriosis. Nobody really knows, but that was sort of the
Yeah.
reason behind that theory.
Yeah. That's
So yeah, but it
fascinating.
doesn't explain so many of these other situations. And some people say maybe there's multiple different
Yeah.
diseases. It's not just one disease. So it could
Yeah.
be that there is more than one cause. So
Yeah, it's fascinating. So we've talked about what it is. We've
mhm.
talked about symptoms,
Yep.
both common and uncommon.
Mhm.
How do you get a diagnosis? You talked about how it does not always show up on imaging. I cannot
Yeah.
tell you how many of my patients say, I have all these symptoms, pain, GI issues, urinary issues, fatigue, all this stuff. But I had an ultrasound, I had a CT scan, I had an MRI, and
Mhm.
I don't have
Yeah.
endometriosis. And I'm like, no, 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 that
Yeah.
doesn't mean that you don't
Doesn't
have
either.
it. So
Yeah.
how do we figure it out?
Yeah. Oh, so interesting. A lot of people are told that, and you'll see this either in comments on social media or patients will come in and say, "Oh, I was told I don't have endometriosis," and I'll be like, "Oh, you had a surgery?" They're like, "No, no, no, no. I had an ultrasound and it was negative," and I'm like, "No, it doesn't rule out endometriosis." So the only way to know 100% is the surgical diagnosis, and even not necessarily just looking during the surgery, but having the actual tissue pathology, because sometimes like it can look like dark spots, clear blisters, white spots, even like just like breaks in the tissue. So
Hmm.
it looks lots of different ways, and sometimes like even in like kind of experienced hands, it can be hard to tell. So most of us who are endometriosis specialists will pretty much anything that looks like endo during a surgery will try and cut out,
Hmm.
just to be careful and remove whatever we can. But the surgery is sort of the definitive diagnosis and treatment. We just try and kind of like remove as much as we can. You can have a suspicion for it. We can what's called a clinical diagnosis, meaning that, based on your story and your symptoms and our thoughts about likelihood, yeah, we think, okay, you probably have endometriosis based on all of this. Like there's people who are, I'm like, if I had to put money on it, like I would put money on you having endo. So, we just say we just can't confirm it 100% without the surgery. So this is where, doing the laparoscopy, having the excision, that's sort of our gold standard. And especially
Yeah.
for someone who wants to get pregnant, because again, a lot of times what happens, especially if someone's younger, like a teenager in their 20s, like they're just going to get started on the birth control because one, a lot of people just need birth control. They don't want to get pregnant. They need it for that reason. And also because it's obviously less invasive than doing a surgery. So most people will kind of start with being put on birth control, but either if you want to get pregnant again, you can't be on it forever,
Right.
or if you have side effects from birth control, or if you're like, look, I just need to know. I want to find out what's going on with my body. I just want to have an answer. So all of those are reasons to do the surgery. So, and it's interesting. I was going to actually point out when you said about your patients who get diagnosed, even if they're not having major symptoms, I will say there's actually some studies. I think that it's confirmed that the amount of disease is not correlated with the amount of pain. In fact, it's almost the opposite, the inversely
Mm.
proportional, where the people with the worst pain sometimes have the least disease, and the opposite, those who are like, I'm actually not feeling that bad, don't feel a whole lot, but I'm having unexplained infertility, and someone does a laparoscopy, or they may on ultrasound have a huge endometriosis cyst that's discovered as part of a fertility workup,
Hmm.
and it turns out that they have terrible disease. I actually find that quite a lot, that the people with the worst disease are the fertility patients who have almost no symptoms.
Yeah.
And my theory with that is, like, obviously if you have really sensitive nerve endings, like, you're going to have way worse pain and get diagnosed at an earlier stage. And if you're like, actually really feeling it's just going to quietly get worse and worse without you knowing, because you don't
Mm.
feel very much, and it's just going to be like this occult like worsening of disease, and then finally when you get diagnosis, it's really, really bad. So some of the ones where I'm like, holding my breath are the fertility patients with,
Yeah.
like, not feeling so bad, but find a huge cyst on ultrasound. I'm like, oh, it's going to be a long one. It's going to be a long
Yeah.
surgery. And they
I
end up
hadn't
having the worst disease. Yeah.
Yeah, I hadn't thought about that, that just the lack of symptoms allows for, a build up of disease over time.
Yeah.
That makes a ton of sense. Whereas if you're having a lot of pain, you're going to, figure this out a little bit sooner.
Yeah.
Do you ever use the endometrial biopsy with testing for
I
BCL6
haven't had access
for
to that.
testing?
Yeah. So
Yeah,
go ahead
it's
and
something that
describe that. Yeah.
it's something that I do sometimes use in my practice because, we are seeing people probably for different reasons. So I'm seeing
Mhm.
somebody that um, wants to get pregnant, and I'm worried that endometriosis might be a part of their picture.
Mhm.
So certainly if they have pain,
Mhm.
we're thinking about surgery, or we're thinking about suppressing estrogen, suppressing
Mhm.
ovulation, with some sort of progesterone,
Mhm.
for pain. But if you're trying to get pregnant,
Yeah.
you
Can't do it.
can't, you got to ovulate. And honestly, my treatments, like the way I stimulate, ovaries for IVF, or when I'm doing a frozen embryo transfer, I do have different protocols if I really know and think somebody has endometriosis or not. And I don't want to do a diagnostic laparoscopy on everyone
Mhm.
who is undergoing fertility treatment.
Mhm.
It's, risky, time off of work,
Mhm.
just all of those things. And quite honestly, IVF is so highly successful.
Mhm.
I think that's what really the tipping point is, to sort of less diagnostic laparoscopies.
Mhm.
So,
Oh, so question about the endometrial biopsy, because we don't have access to that test. Like, is that commercially available where you are?
oh yeah, there's
Oh
a
my God. Okay.
company that's called Receptiva,
Yeah. Uh-huh.
and they just send you kits, and you can do an endometrial biopsy. It's got to be in the luteal phase.
Mhm.
So somebody cannot be trying to get pregnant that month. So
Mhm.
after ovulation, that's when you do the endometrial biopsy and send it in to see if they have a high level of BCL6. And if they are over a certain threshold, there's an over 90% chance that if they were to do a laparoscopy, you would
They
find
would have died.
endometriosis lesion. So it's
Interesting.
not
Yeah.
the gold standard. The gold
Mhm.
standard is still a laparoscopy.
Mhm.
But if you have a suspicion and you're trying to decide, gosh, should I do this intervention for someone who's trying to get pregnant or not? Because treatment for fertility with endometriosis is usually a lot of downregulation with
Mhm.
Lupron, and that can
Yep.
have its side effects. And so that is a non-invasive way, although endometrial biopsies are not very fun,
Mhm.
but it is not a
Less invasive
laparoscopy
than a
way to
laparoscopy. Yeah.
get. But I always really
Mhm.
try to be very careful about, like, it is not the gold standard. The gold standard is surgery.
Mhm.
But especially if someone's not having a lot of pain,
Right. Yeah.
we're kind of thinking like, okay, if you're trying to get pregnant and we've done IVF and we've got embryos waiting for you, how are we going to quiet this inflammation before
Mhm.
we actually try to get you pregnant? And I
Yeah.
talk to people about doing surgery or doing downregulation medically, progesterone or Lupron or
Mhm.
something like that in order to try to get pregnant.
And that is so
Um,
important. I will point out,
mhm.
I've had, like not like a small number of patients who, either because they're going through IVF or like egg freezing, they have horrible spikes in pain because we mentioned endometriosis is sort of stimulated by estrogen. And obviously when you're doing like this kind of like, like this process where you're stimulating a lot of like, follicle development, their estrogen goes very high. And so people can have terrible pain with this. And so it
I
is
know.
so important to kind of have that suspicion. And, like you mentioned, there are different protocols where you're suppressing and you're doing more down regulation. So you're not, it's like, hey, we're just going to like get that estrogen as high as we possibly can.
Oh, I
Which
know.
is can lead to terrible pain. I've had patients who that's the first time that they have really bad pain. They're like, my
Yeah.
periods are like okay, but then like I was going through IVF and it was like horrible. So I think,
Yeah.
being really, sensitive to that possibility is so important. And actually that having that I can't speak, receptiva option is great because like you said, if a patient doesn't have the pain that would bring them to the surgery anyway,
Hmm.
if they're like, I just want answers and I want to optimize my fertility outcomes, then, it's not quite so clear cut going to the
Yeah.
surgery part. So I think that's really important. And then actually, somebody mentioned another situation where that's really helpful is in countries like the UK, where there is such a backlog, a wait to see a specialist and get surgery. It can help to
Mm.
triage those who, maybe really, definitely have a high suspicion for needing the surgical involvement versus those who have a low potential and maybe they could be better managed, with medical interventions over time. And so I actually was like, oh, that makes a lot of sense because
Yeah.
if there was a more accurate way to say, okay, you're okay to wait, or you probably should be fast tracked to the surgical option, I think that's really important. So,
Yeah, that makes a ton of sense. We're going to take a break and get back to talking to Dr. Tang in just a minute, but I want to remind you just how important it is to support the show. If you are finding valuable information in this episode, share it with a friend. Wherever you are listening to this podcast today, follow the show. That's an amazing way to help us get discovered and help other people get more education for their reproductive health. When you follow the show, take a minute to review the show. A 5-star review with a little bit of an explanation of why you found it valuable can mean so much. Thank you so much for being here and supporting the show just by listening. Now let's get back to talking to Dr. Tang. So someone has a diagnosis of endometriosis,
Mhm.
treatment options. And I know this totally depends on whether they're trying to get pregnant or not, but
Mhm.
let's talk about, treatment options. Can you break it down for someone that is coming to see you for especially pain?
Yeah. So we talk about the different things in terms of, symptom management, and then, the diagnostic stuff. And for endometriosis, the diagnosis and the treatment are kind of wrapped up together in the surgery. But when we talk about kind of symptom management, we say that things like hormones, like all the birth control methods, progesterone of any sort, does seem to suppress the endometriosis activity. Like you mentioned, it's all inflammatory. So sometimes quieting that activity, decreasing inflammation makes your symptoms a lot better. So like we mentioned earlier, there's a lot of people who do just fine with just birth control, and that's plenty to treat their symptoms. So
It's a good time to point out that the dominant hormone in a birth control pill is progesterone. Because
Mhm.
I can imagine being a listener and being like, wait a minute, Dr. Tang just said that estrogen inflames endometriosis. And
But there's
isn't that
estrogen in my
what?
pill. Yes.
Right,
Yeah.
right. So I just want to clarify that because I
Yeah.
think that's a really common, misunderstanding.
Yeah. And we always have to kind of mention too, because people think, well, you're giving me estrogen. That's very confusing. And so the purpose of the birth control is actually to suppress the signals from your brain that stimulate your ovaries production of, estrogen and also ovulation. So if you were to draw someone's blood who's on birth control, they'll actually have fairly low estrogen levels because it's quieting, your brain's activity and the ovaries activity. So the overall effect is to have a lowering of the
Mm.
estrogen. So it is a little confusing because you're like, wait a second, you're giving me the thing that makes this worse. Why? But yeah,
Yeah.
we're using it primarily for the progesterone effect, which is the, quieting. And so that's why we can also use things that aren't birth control, like norethindrone, or brand name is Agestin, which is a common medicine that we use for endometriosis treatment, is not a birth
Yeah.
control. It's just progesterone tablets,
Yeah.
a stronger dose than what's used for birth control. control. And then there are medicines that actually directly kind of quiet that signal. So this is your Lupron injection, your Orilissa, Myfembree, which are medications that kind of directly suppress that signaling to the ovaries and kind of quiet the hormone effect.
Yeah.
Those are not meant to be used forever. They do have a limit on their use to 2 years, because, or even shorter depending on the dose, because we obviously don't want to, permanently suppress someone's hormones, because that can lead to things like, like bone loss and cardiovascular disease, and also just like symptoms of like menopause, like hot flashes and things. So, but those are good for kind of like temporary management of pain and symptoms
Yeah.
from endo.
What about progesterone IUDs?
Yeah, they do work. So there's research on those. I do tell people, for the really bad endo, especially the ones that involves their ovaries and stuff, it's not enough, because it's not kind
Mm-hmm.
of, meant to go super systemically. Like most of it kind
Mm-hmm.
of stays relatively close to the uterus. But it does seem to, in studies, help with pain and symptoms. But it obviously doesn't suppress things like ovarian cysts and things like that.
Yeah.
So it depends on kind of the severity of symptoms. It's great for people who have like the bleeding issues, like you said, with the
Mm-hmm.
endo, it makes them bleed more.
Mm-hmm.
There's also something called adenomyosis, which I call it's like a cousin of endometriosis. It's in the muscle of the wall of the uterus rather than outside, but they behave very similarly.
Mm-hmm.
It's just that the adeno tends to cause more bleeding problems. And then the surgery for excision. So what I would love to dive in with you to talk about is cyst management. So
Mm.
endometriosis cyst management is a little bit more of a controversial topic, because there are some downsides to doing a cyst removal, which is, to take a cyst out of the ovary, you actually have to cut the ovary open.
Mm-hmm.
So I used the analogy of having two balloons, one inside the other. The cyst is the inner balloon and the outer balloon is the ovary. So you have to cut the ovary open to get to the cyst to take it out. And in the process, you lose some eggs. So this is where, for fertility patients, it is a little bit of a rock and a hard place, because, well, the endometriosis itself can affect the egg quality because it's inflaming them. And also it can block your tubes, which is next to the ovary, because of
Yeah.
scar tissue and inflammation. So, there are times that we're like, well, you definitely need to have this surgery because it might adversely affect your fertility. But if it's a small cyst, is it worth the damage to the eggs and the ovary that you take that risk to get rid of the disease? So there's no right answer. So this is
Yeah.
where we tell people there's not like a cut and dry answer to this. It's a little bit of, based on how, what symptoms you're having, if your fertility is the primary concern, how big is the cyst. Obviously, if
Yeah.
it's a huge cyst, most fertility doctors will say, yeah, that's got to go, because it's just so big. It's going to, likely cause some sort of problem with the tube or the eggs and things like that. If it's very small, like it's a 1 centimeter, pretty much everyone will say, leave that alone. It's not worth damaging the ovary
Yeah.
for. But in between, there's a lot of gray area. So I would love to kind of hear your approach, and, if
Yeah.
you have any specific things that you tell your patients.
Yeah, you're bringing up so many good points about how important it is to find, a specialist with
Yes.
this, right?
Yes.
Because there is not a one track way. Like
Mhm.
every medication that you mentioned
Mhm.
has side effects. Like the
Yep.
reason Lupron causes bone loss is you are absolutely suppressing estrogen production. So that is
Mhm.
great for quieting endometriosis, but if you don't have estrogen, you're not building your bones,
Mhm.
and you've got a cyst. Not all ovarian cysts need to be operated on, and not all ovarian cysts are causing fertility issues.
Mhm.
And it is, it's like fibroids. Like not every fibroid is causing a fertility
Mhm.
issue and needs to come out. But it should be discussed. And every cyst has a potential of having abnormal cells in it, right?
Mhm.
So you
Yep.
can't see a cyst and be like, oh, that's just an endometrioma. Don't worry about it. And it's probably fine if it doesn't change and it's not causing you symptoms.
Mhm.
But yeah, it doesn't just automatically need to come out. And you're exactly right. You need to be cautioned that there's no way to just only get out the endometriosis tissue, that you're probably going to lose some good ovarian tissue and lose a little bit of your egg supply, which is so precious when you're
Mhm.
thinking about your fertility. And that is why a lot of people will come to me as soon as they get a diagnosis of endometriosis, maybe even before their surgery, with an expert like you, and they'll do fertility preservation.
Mhm.
So they'll do maybe an egg retrieval and freeze their eggs before they go in to
Yep.
do a surgery.
Yeah, I've done that. Mhm.
Because,
Exactly.
yeah, especially if you have a really large ovarian cyst, even in incredible expert hands, there is a chance you could lose that whole ovary.
Mhm.
it's very rare, but
Mhm.
like things happen in surgery. And so sometimes people are like, listen, I don't know what's going to happen in this surgery. It could be an extensive surgery. I want to just freeze some eggs before I go in. I'm
Mhm.
not ready to have a baby. Or, sometimes people will come to me with very significant pain, but they want to have a baby.
Mhm.
And so we're thinking about these different paths. And sometimes I talk to a patient about, well, maybe what we should do is do IVF now, like get eggs out, create embryos, have them frozen, and then have a surgery
Mhm.
with an expert that can take out that endometrioma or cyst in your ovary, really do amazing excisional, work on your lesions. And then you're going to feel so much better.
Mhm.
The burden of that endometriosis is going to be so much less when you're actually trying to get pregnant.
Yeah.
But that, high estrogen level for 2 weeks when you're stimulating the ovaries to get the eggs out, you're doing that
Yeah.
before you fix everything,
Yeah.
so kind of, and I know that, oh my gosh, access is a huge issue. Cost is a huge issue.
Mhm.
It is very, ethics are strong when it comes to IVF. There are absolutely people out there that would never do IVF. But in a perfect world, if you're my best friend or my sister and you're having a lot of pain and you really wanted to have a baby, I would say do IVF, freeze eggs, freeze embryos,
Mhm.
go to an expert, and then try to get pregnant when you're ready.
Yeah.
Let's talk about surgery and
Mhm.
ablation
Mhm.
versus,
Ha.
the different types, because I get asked this all the time on
Mhm.
Instagram, YouTube. How do I find a good surgeon? And my patients are like, oh, will you please do my laparoscopy? I'm like, no, I will not do your laparoscopy. You don't want me to do your laparoscopy. I was not trained in robotics. I was not trained in excision, and you really don't want me to do it. So tell the listeners what the difference is,
Yeah.
and oh my gosh, how do they find someone? I mean, obviously they
Yeah,
should come to
you know what's
Philly
so
to
funny is
have
that
you.
we were talking about how how old we are, but so back when I was in residency, the fertility doctors were the endometriosis experts. Like
Mm,
there were what we call minimally invasive GYN surgery or MIGS, which is my specialty, is a relatively new one. Like when I was in residency, so it was 2005 to 9. There were only a couple of programs in the country that were training surgical specialists in things like endometriosis. It had been just always like, oh, there was just experts and they
yeah,
just, were experts. They didn't have a specific like subspecialty named after it.
yeah,
So they had just kind of begun to start doing the fellowships kind of like around that time. The reproductive endocrinologists and fertility specialists were the endometriosis specialists. Like they did a
yeah,
lot of surgery. Same thing for fibroids. So fibroids and endometriosis were kind of REI territory. And it's interesting because, as you said, is like IVF has gotten so successful, and as people sort of niche to like, well, I don't love doing surgery. I love doing like cycles. It became more natural that then the surgery kind of dropped out and then became minimally invasive GYN surgeon land, and then the fertility stuff was just the fertility stuff. So
yeah.
it is very interesting because things have changed over 20 years very much in terms of who you see. And so
Absolutely.
now I
And
would say
part of it is
nowadays, yeah,
I'm that generation where it really did start to
it
change. And it
changed
also
over. Hmm.
depends where, because I
Hmm.
did my fellowship at Stanford. There was Cameron Najat,
Oh yeah,
who
yeah, yeah.
is
Hmm.
a endometriosis kind of
Guru, yeah.
legend. And so
Hmm.
he had sort of his own fellowship.
Hmm.
And so we would sometimes do surgeries with him,
Hmm.
but my particular fellowship wasn't very surgery heavy.
Interesting, yeah.
Again, this is a long time ago, but yeah, it's really, really changed. And because the MIGS fellowship is so great and
Hmm.
there's incredible people that are totally dedicated. Anytime you're looking for a surgeon, you
Hmm.
want to go to someone that's operating every
A
single
lot.
week and
Yes, yes.
multiple surgeries every single week,
Yeah.
because those are the people that are going to just have the most expertise. And that's really important.
Yeah, it's super important. And it's a bunch of reasons for that. So one is just experience. These surgeries can be very hard surgeries. And that's
Yes.
why a lot of general OBGYNs who are amazing, like they're great, they're handling a million things. But if they're not doing a lot of surgery, then if they get into the, like one surgery a month or even every couple of months where they're doing endometriosis, and if they're like, oh shoot, it's like right near the rectum, it's right near the ureter, I'm a little bit nervous about hurting those things. So they're more
Totally.
likely to kind of like leave stuff behind.
Yep.
And so and also just recognizing what endo can look like. That, like I said, it can look like like a lot of different things. So I've definitely had patients, and all of us who are specialists who have seen this, where someone's had a surgery and been told you don't have endo, but they didn't take any biopsies. They just kind of like looked at stuff. And then you go in there, you're like, there's all this endometriosis. It just
Yes,
looks very subtle. It can be like
totally.
tiny, like
It's a
one
really good
millimeter
point.
clear blisters. So you can barely see them. So you really
Amazing.
have to kind of have that knowledge about what it could be, like, have the ability to kind of safely remove them. And also not just the surgical stuff, but also we train in the management of pain. So our subspecialty is also kind of pain management. Like we work with pelvic physical therapists. Very, very common. Almost everyone with endo has some sort of muscular involvement because the muscles get
Mhm,
inflamed. So then
mhm.
that also affects like their bladder function. Like it causes pain with sex, it causes like constipation and all these other things. So, it's also about like having that knowledge of the other things that can need treatment, not just doing a surgery, not just giving medication, but just being like, I call it the ringmaster of, okay, you need to see a pelvic physical therapist, a urogynecologist. We try like these trigger point injections. Like there's different things that are done, not just, with the surgery. But in terms of finding someone, so it is a little bit tricky. There's not like kind of like a credentialing process. It's sort of,
Mhm.
like there are people who just kind of, it's almost like word of mouth. Like you find these doctors who are specialists. Um, like if you look for someone who's fellowship trained minimally invasive GYN surgery, meaning they have like a formal training process through our American Association for Gynecologic Laparoscopists, it means that they had at least some sort of curriculum involving surgical management, endometriosis, evidence based. They know about chronic pelvic pain, so at least then you have some idea that they had like some basic training
Mhm.
behind them. And then a lot of it too, just word of mouth, like, wherever you are locally, like there's different groups, like a lot of now, a lot of like endometriosis support groups. Like there's various local ones in my area, and they're great about recommending doctors who, people had a really good experience with, they have really good outcomes.
Yeah.
um, and then in general, like, you can also ask your gynecologist, like your OBGYN, because they should know too, like for their own referrals, like hopefully they are referring,
Yeah.
that they can ask, like, who is a good endometriosis specialist in this area? Can you recommend? Because a lot of them now, like, they don't want to do the surgeries. Like you said, they're like, this is not what I do. And you're better served being with someone who does this a lot. So
Yeah.
a lot of OBGYNs will have people that they refer to, and you can kind of vet them, looking up their background.
Yeah.
There is something called Nancy's Nook, which is a huge social media group. It definitely doesn't include all the endometriosis specialists. I am actually not on there for various reasons, but it's a good starting point. At least you can kind of do some sort of search for endo specialists in your geographic area. And like I said, just
Okay.
look up endometriosis support groups as well, kind of near you. And a lot of people will have discussed like doctors that they liked and had a good experience with.
That's great.
Yeah.
Yeah, and I mean, even I didn't learn excision,
Oh
when
no.
I was
Yeah.
treating. So what's the difference between
So
like,
let me, that was
yeah.
your original
Yeah.
question I didn't answer. So when you talk about like removing the endometriosis, like you can either destroy it, usually by like heating it, and that's called like ablation or cautery, versus cutting it out. And what I tell people most of the time, what we're cutting is sort of a clear coating that grows over all the surfaces in your pelvis. It's called peritoneum, and I say it's like a saran wrap that kind of is coating everything. So most of the time, we're sort of picking up that coating, we're cutting it out with scissors or electrical instruments or lasers, and sometimes like the fatty tissue underneath the surface. More rarely, but still, not uncommon, it actually grows into other organs like the bowel, the rectum, the bladder, and then it is more of a multidisciplinary approach where you have like a
Mm,
colorectal surgeon, like a urologist. They're actually like kind of cutting out pieces of those organs. Luckily,
mm,
most people that know don't have that bad disease, but some people do. So, when we're cutting it out, there's a couple of reasons that most of us who are experts prefer the excision part. And then when you look up endometriosis online, you'll see a lot of this excision versus ablation. So, the ablation we say is problematic for a couple of reasons. One is that if you just burn it, you don't have a specimen, so you don't actually know if it was endo or if it wasn't. So sometimes you'll see these operative reports where they just burned everything, and you're like, I don't know
yeah.
if you have it or not. Like we don't
Yeah.
have any proof. Um, so just one, in terms of accuracy of diagnosis. Number two, in terms of getting it all. So it's sometimes like the tip of the iceberg situation, where on the
Mm,
surface it may not look like very much, but when you start kind of dissecting underneath it, you'll find a huge nodule that goes
mm,
much, much deeper. And there's no way to get all of that without cutting it all out. Like you can't just burn the surface. It's not going to get all of the kind of deeper tissue stuff. So I tell
Yeah.
people, if you don't do any excision, you're missing 100% of what we call deep infiltrating endometriosis, where it's growing below the surface. So you literally have, you're just automatically missing all of that deep disease. And then the third is safety. So we mentioned about it's always right near something dangerous. So it's
Hmm.
always near the rectum, the ureters, blood vessels. So the problem is that endometriosis almost never grows somewhere super far from everything else, in the middle of nowhere
Oh.
in your abdomen. It's always next to other dangerous stuff. And the problem is if you burn things, you're more likely to injure that other stuff. And
Oh,
that's
that's a good
why,
point.
yeah, for safety. And that's why a lot of people will leave it there because they're like, well, if they only burn stuff, they're like, well, I just don't want to burn the rectum. So they leave it there for safety reasons, but then it ends up just growing worse and worse. And so I tell people it's actually much safer to pick it up and pull it away and cut it out with cold scissors, we call it, without the heat. And then there's minimal risk of injuring it if you're very careful. And so, when we cut it out, it's actually much safer because you don't run that risk of the heat actually damaging other sensitive structures. So for all
That's
those
great.
three reasons, that's the reason that most of us will do excision primarily. And it's also to
Okay.
make sure that like you kind of cut what we call a margin, like you not just the little dot, but the space around it to make sure that any like microscopic cells you get as well. And so
That's
there are some
great.
people, and again, there's no right or wrong answer for this. There's some people who literally strip everything. So they call it like a complete peritonectomy, where they
Oh boy.
literally like the whole, space between the uterus and the rectum, they're stripping everything. And for me, that's a little bit more extreme. Like there's always a risk of scar tissue forming with that. So again, it's not like that there's a right or wrong answer, but some people, because they're really worried about missing microscopic disease, will be very aggressive and cut like almost everything out. So,
Mm.
that you balance getting everything as much as possible, including microscopic stuff, with the potential for scar tissue formation. So
Okay.
again, a lot of this is sort of based on like expert experience and, things like that. So, or,
Okay.
if
Oh my
somebody's had
gosh.
like 2 surgeries before and had it come back every time, then you might be like, okay, like let's be more aggressive with the stripping and things like that. So,
Okay, thank you. That's
yeah.
really helpful information. All right, well, I reached out to my followers on Instagram because I was
Yay.
like, I am talking to superstar Dr.
Woohoo.
Karen Tang today. And I just said, what questions would you ask for her? And I came back with 2 that kind of kept
Okay, come
repeating.
up
Okay.
over and over again. Yeah.
So first one was my doctor told me to just get pregnant to fix my endometriosis.
God.
And I want to tell you, I actually,
God.
I interviewed my mom for this podcast
Uh-huh.
about a year ago, and she had that. Like she had very painful periods, horrible periods growing
Mhm.
up, horrible endometriosis. And after she had my sister, she honestly had less pain.
Oh my gosh.
So I know that there is some just sort of anecdotal,
Mhm.
history and sort of things like that. But like, why are doctors still saying this?
It's wild, right? It's a very
Yeah.
common thing that people are told. And so I think it was the Jonathan Van Ness podcast, we were talking about this. And I will say there is some physiology to it for very reasons. Like people tend to have worse symptoms when they're on their period or when they're ovulating. Obviously, when you're pregnant, you're not ovulating or on your period for all of that
Yeah.
time. And also the progesterone that goes up in pregnancy, we mentioned, suppresses endometriosis. So you have high progesterone, they feel good, they're not having periods. So people do feel better while they're pregnant. The problem is oftentimes, most of the time, after you aren't pregnant anymore, you've had the baby, all of it goes back to normal. So it's not
Yeah.
like a long-term fix. And especially if someone's like, like a teenager, like I hear people are told this when they're teenagers. They're like, well, if you just get pregnant early,
Oh my
I'm like,
God.
I'm like, they're not going to stay pregnant for 30
I
years. I
know.
mean, that
I know.
it's not a I say it's not a long-term solution. So,
No. Like,
especially if
okay.
someone doesn't want to be pregnant.
I mean,
Um,
exactly. I mean, it's
yeah.
very just, yeah. Okay. So,
But yeah, so
I mean,
that's
there
not a
are
long-term
some
fix. Yeah.
anecdotal stories like my mom
Yes.
that actually did happen, but that
Mhm.
doesn't mean that it's going to work for everyone. Okay. The
Right.
second question that came up a lot is a hysterectomy going
Ah,
to fix me?
no. So back to the kind of the myth we were talking about with the retrograde menstruation. So that myth that hysterectomies fix it comes from 2 things. One is that there is evidence that having a hysterectomy does decrease the chances of you needing another surgery in the future, but it's almost certainly because the uterus was then the cause of the pain. So we mentioned adenomyosis,
Mm.
which involves the uterus itself, has very, very similar to almost identical symptoms as endo, but
Mhm.
you wouldn't know that you had it unless you take the uterus out. So again, it's one of those things that you can't like biopsy the uterus. You can't kind of, like sometimes with imaging, you might be able to see certain like blotchiness of the wall of the muscle on imaging that suggests it. So,
Okay.
but you might not necessarily know. A lot of times, again, uterus looks totally normal on imaging and you would never know. So, most of the time, when you do a hysterectomy and you feel better, it's because the problem was your uterus. It was the adenomyosis,
Mm.
or just some people have horrible cramps just for unknown reasons. So it can make you feel better, but it's not that it's preventing endometriosis. So,
Yeah.
like we mentioned, people can and do have recurrences of endometriosis even after their uterus was removed. So it is something that if you are having a lot of symptoms like bleeding, heavy bleeding, maybe your imaging shows some, we call heterogeneous myometrium, like some blotchy looking muscle. It's also very common, especially after someone's had C-sections or uterine
Mm.
surgery like DNCs or
Mhm.
myomectomy to cut fibroids out. So if that's your story, if you're like, I was doing okay, and then I had, a C-section or two, and just the periods got horrible, and that's the
Mm.
classic story for adenomyosis.
Mm.
Um, then in that case, a hysterectomy could be indicated because we think the problem is your uterus, but it does not prevent endometriosis from coming back. So it's not an
Yeah.
endo treatment in and of itself. And that is a
Yeah.
myth. There are sometimes that people have known endo that's growing on their uterus, like on the outer surface, like it's coating the back or it's sticking between your uterus and your rectum. And then a hysterectomy is part of that because you're removing the diseased
Mhm.
uterus has the endo on it, but in and of itself a normal uterus being removed is not going to fix endometriosis or prevent
Yeah.
it.
Yeah, it's so hard because I have had people who were hoping that that was
Oh
gonna be
yeah.
the answer, and they still
Oh, they still
have
have pain.
pain.
Yeah.
Yeah,
Hmm.
it's horrible. Oh my gosh, this has been such a valuable,
Yeah,
incredible
we could go on and
interview.
on.
Lear
Like
I
I was gonna
know.
say, good thing we're doing
Oh,
another episode.
I know.
Stay
You're
tuned
amazing.
because yeah.
But I would love, Karen, if you could just leave the listeners with, people who are listening to this and saying like, oh my gosh, like this is me.
Mhm.
I need to figure this out, but I'm so scared to just bring it up with a doctor because every time I've been dismissed. Can you
Mhm.
just give some words of wisdom or encouragement to that person that's listening and sort of saying like, I've got to address this, but like, how do I advocate for my care?
Yeah. And so actually at the very end of my book, it's not hysteria. I actually have a chapter on, how to talk to your doctor, how to advocate for yourself, like what to do if your doctor's not listening to you. So, for the full, discussion, which could go on and on, look at the book. But in general, you deserve answers. And a lot of times people get sort of the brick wall response, which is like, well, that's it. I've run out of things to offer you. We've tried every birth control and there's nothing more. So, you can ask your doctor, I have all of these symptoms, X, Y, and Z. I think I have endometriosis. I'd like to talk about different treatment options. I'd like to talk about my fertility. And then if they themselves don't have much to offer, that's where you say, can you refer me to a specialist?
Yeah.
Because, like rather than trying to beat your head over, over and over again and getting kind of not much helpful information, like then you just go to the specialist, the person who does this all day long. They say a
Yeah.
million patients a day who have the same story, and they know kind of how to kind of take you along that journey. So and then if your doctor can't recommend someone, this is where you crowdsource and you find
Yeah.
like groups and like local recommendations. But I tell people, like, once you're kind of on the train tracks, like that is when you're going to be okay. Like it may not be like that your pain is immediately resolved, but you're in expert hands where all the things that you're going to need to talk about, medication, surgery, fertility, pelvic floor, all of that stuff is going to get addressed in some way. So just to have that hope that we are out there. And it is tough if you have listeners who are in other countries. It is very difficult, like sometimes for
Yeah.
people to get access to specialists. In the US at least, sometimes like you have to travel, but
Yeah.
there are specialists out there, but just to know that if you get into care, that you're not alone, it's not in your head, you're not imagining in it, like there's something physically going on, and that you deserve to get treatment. So
Yeah. I think just knowing that there are doctors out there like
mhm,
you can be really helpful to the listeners because they might have only experienced doctors that just sort of dismissed symptoms or sort of said, well, there's nothing else to offer. And so just
mhm.
knowing just to keep finding, keep asking and finding that right person, it
Yeah.
just
And
brings a lot
if
of
any of
hope.
you want to come outside of Philadelphia, so my office is in Bryn Mawr, Pennsylvania, so like a little bit outside of Philly. So thrivegyn.com. So like thrive, like you're going to thrive. Thrivegyn.com is my website. And if you just look up KarenTangMD.com, also everything links to that as well. So you can find me, the social media, the book, the practice, all of it through KarenTangMD.com. So
perfect. Oh, Karen, thank you so much
this is
for
so
being
great
here today.
Oh, thank you for having me.
Absolutely. I hope you found this episode valuable. I have cared for people with endometriosis for over 20 years, and I am often the second, third, fourth opinion. And I love that the education about how to understand symptoms, how to advocate for your care is getting out there. And Dr. Tang really helped nail home some very valuable tips today, and I'm so thankful for that. You can find this episode and all others of the Baby or Bust Fertility Podcast on my website, drlorashahine.com. You can find more educational content from me on Instagram, on YouTube. I just love teaching. Thank you to our friends at Seattle Sperm Bank and Braze Run Production for sponsoring the show. Thank you to my producers at Audiotocracy for your incredible work. This is your host, Dr. Lora Shahine, and until next week, wishing you love, luck, and pineapples.